I'd like to introduce my beloved Ahmed Bendary. Dr. Ahmed Bendary.
Hello, everybody. I'd like just to recap what have been said in just 10 minutes. This disease, again, is underdiagnosed, underreported, and unfortunately undertreated. If we are going to see the pathophysiology, we will have a long list, about 12 pathophysiologic mechanisms. And let's start by genetics. We have now evidence from twin studies, التوائم, that have demonstrated a very strong hereditary component, up to 50%, to both hepatic fat content and hepatic steatosis. And moreover, genome-wide association studies have identified what we call loss-of-function mutations, which are protective against the development of NAFLD. The second theory is lipid accumulation, and it goes without saying if we consider that the major sources of triglycerides into our body come from fatty acids stored in adipose tissue, and of course, fatty acids synthesized as de novo synthesis through de novo lipogenesis in the liver. The third pathophysiologic underpinning is the insulin resistance. And of course, insulin resistance has a key role in the development of hepatic steatosis and potentially steatohepatitis, such as this study that evaluated insulin infusion in normal subjects and subjects with NAFLD and subjects with non-alcoholic steatohepatitis. Hepatocellular injury comes from free fatty acids, which are considered inducers of cytochrome B450, which induces what we call microsomal lipoxygenase enzymes, which are capable of producing hepatotoxic free oxygen radical species. And then, if we look to antioxidants, we will have a very significant correlation between the disease severity and increased expression of what we call oxidative scavenger receptors, as shown in this correlation figure. Iron, and someone pointed to iron during his presentation. Suffice to know that the prevalence of the heterozygosity for the hemochromatosis gene mutation may be increased, significantly increased in patients with NASH compared to normal subjects with increased hepatic iron concentrations, and this could lead to elevation in the liver enzymes. Now let's dive into the GIT, and let's start by leptin. Look with me to this very important study published in the Science, in which leptin was found to induce dephosphorylation of insulin receptor substrate 1, and this could lead subsequently to insulin resistance, which could culminate finally into non-alcoholic fatty liver. Adiponectin has also been found to be associated with NASH, especially those patients with markedly reduced adiponectin compared to controls. The p-value here, as you can see, a lot of zeros. Resistine has also been found in some mouse models to be associated with hyperinsulinemia, especially if they are overexpressed, with impaired suppression of free fatty acids, which are injurious to the liver. Incretins, and I'll come to this later, the intestinal microbiome, this is the new fashion. Small intestinal bacterial overgrowth was observed to be associated with increased incidence of NASH. Look with me to this study published in Gut, which is one of the major journals of PMJ, in which investigators studied the association between small intestinal bacterial overgrowth and non-alcoholic steatohepatitis, and they concluded that patients with non-alcoholic steatohepatitis have a high prevalence of intestinal bacterial overgrowth. And finally, before we speak about the management, let's look to the bile acids. Suffice to know that deficiency of bile acids could be associated with increased incidence of non-alcoholic fatty liver. Look with me to this interim analysis published in The Lancet of a major cohort study in which OPT cholic acid in a dose of 25 milligram daily has been found to be associated with greater improvement in hepatic fibrosis compared with placebo. And now to the very beautiful part of the presentation, it's the management. I don't like to repeat what have been said, but please keep in mind that the spectrum of the disease is not benign. It could culminate finally into cirrhosis and even hepatocellular carcinoma. And we have patient-related and disease-related factors that could increase the progression from NAFLD to fibrosis. For example, older age, diabetes, alcoholic use, obesity, and the disease-related factors, the elevation in the liver enzymes, the histologic evidence of inflammation and ballooning degeneration. We have also some grading and staging systems for the disease. The grading system looks to the steatosis by the pathology, and the staging system looks to the fibrosis by the fibroscan from the very mild degree grade 1 to the advanced stages fibrosis grade 4. Those are the general measures that should be emphasized in all patients. The patient should abstain from alcohol. They should be given regular immunization of hepatitis A and hepatitis B, and they should be strongly encouraged to modify their risk factors. The patient should be encouraged to control his diabetes. The patient should be encouraged to take statins if he or she has dyslipidemia. But a very important issue is the weight loss. Please remember that weight loss will and be the primary factor in treatment of non-alcoholic fatty liver. Weight loss is encouraged in both patients with overweight and obesity to achieve weight loss at least 5% of the total body weight by lifestyle modification. And if we fail to obtain this target after 6 months, bariatric surgery options should be discussed together with drug options. But please remember that we do have some evidence now in bariatric surgery. Look with me to this important study comparing Roux-en-Y efficacy, gastric bypass efficacy in improving non-alcoholic steatohepatitis. Compare the figure number A to the figure number B. Marvelous improvement. But the great question is, could I have some drugs which are liver targeted to improve non-alcoholic fatty liver? And the answer seems yes. But we should keep in mind that the pharmacologic options are very limited, especially vitamin E, some insulin sensitizers, and I'll come to this later in the presentation. But remember that pharmacologic options should be reserved to those patients who have not achieved their weight loss targets, especially if they are having biopsy-proven NASH, fibrosis stage more than 2. And the approach seems to be dependent to a large extent on the diabetic status. If the patient is not diabetic, you can go to vitamin E. If the patient is diabetic, you can go to some anti-diabetic medications that have shown some outcome improvement in patients with NASH, such as pioglitazone and GLP-1 receptor agonist. Look with me to this important randomized study published in New England, looking to the evidence behind vitamin E and pioglitazone in those patients. Sit down for this. Pioglitazone and vitamin E resulted in significant improvement in liver enzymes, insulin sensitivity, and even loss of weight. But we should exercise caution when prescribing vitamin E to those patients. Please remember that high doses of vitamin E has been associated with increased all-cause mortality in clinical trials. Vitamin E should be avoided in males with personal history or family history of prostate cancer. And also, we should not use vitamin E in diabetic patients because those patients have largely been excluded from those trials. And this goes in direction with the recommendations of the American Association of Study of Liver Disease. I'd like to highlight the importance of GLP-1 receptor agonists for those patients. Look with me to the LEAN study, which was a huge multi-center, double-blind, randomized trial published in The Lancet in 2015. This trial randomized patients with fatty liver between receiving liraglutide and placebo, and sit down for this. Liraglutide was safe, well-tolerated, and resulted in clinically meaningful and statistically significant improvement in histologic evidence of fatty liver in those patients. Not only liraglutide, but also its brother, semaglutide, another major publication in the New England. Semaglutide in its high dose resulted in significant resolution of non-alcoholic steatohepatitis with no worsening of liver fibrosis compared to placebo in this trial. How should we monitor the patient? How frequent the patient should be monitored? The patient should be monitored by liver enzymes every 3 to 6 months after he or she obtains his target body weight. And if the patient is having biopsy-proven non-alcoholic steatohepatitis, and he or she succeeded to obtain his weight target, he or she should be followed every 4 years. And if the patient did not achieve his weight, the patient should be followed every 2 or 3 years. But in the first place, if the patient is not having biopsy-proven NASH, there is no formal recommendations to routinely monitor those patients. The final question, when should I refer to a hepatologist? Number one, please refer to hepatologist if you have transaminites. elevation in the liver enzymes despite loss of more than or equal to 5% of total body weight. Refer to hepatologist if you have clinical evidence of decompensated liver disease such as ascites. Refer to the hepatologist if you have liver biopsy proving steatohepatitis. This patient is going to have cirrhosis and hepatocellular carcinoma after 5 or 6 years at most. And finally, if the patient did fibroscan and you find that the fibrosis is stage more than or equal to 3, please don't touch. Refer this patient to hepatologist. I'm grateful that you listened, and thank you.
Thank you, Dr. Ahmed. Excellent as always.
Thank you, sir.
I have only one question for you. You stated here that production of weight is very important, but we see non-alcoholic fatty liver disease in lean and slim persons due to malnutrition. How do you explain this dilemma?
Actually, obesity or accumulation of hepatic fat is not the only pathophysiological mechanism for non-alcoholic fatty liver. We also have diabetes, insulin resistance, iron, blah, blah, blah. Those patients, despite they are at the goal weight loss, should be searched for another pathophysiologic mechanism. For example, those patients could be given good nutrition. Those patients should be offered vitamin E if they are not diabetic. If they are diabetic, they should be offered glycoprotein, GLP-1 receptor agonist or pioglitazone as an insulin sensitizer. At the end of the day, we do see those patients, but we should remember that obesity or metabolic syndrome or increased hepatic fat content is not the only pathophysiologic underpinning of non-alcoholic fatty liver or NAFLD.
Thank you very much.
Thank you, Dr. Atif, Dr. Ahmed, Dr. Bendary, and I think our main objective usually in our program is to finish in time. And I'm sorry that we are 3 minutes late than the time. So I want to take a picture by the end of this CME day, a nice CME day. Dr. Alexandros, can you join us?